Good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus of today's session is Choriocarcinoma treatment update. So before starting the session, I would like to lighting the lamp and play Ganesh Vandana to give a warm welcome to each and everyone present in this webinar.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you so much everyone for your patience. So let's begin today's session, for which I would like to invite Dr. Dipti Chaturvedi ma'am to take over. Ma'am is present member of executive body.
That's okay. I'm the
Okay.
moderator and convener.
Okay.
So,
Thank you so much, ma'am, and over to you. Please proceed.
okay, thank you. Welcome and hello to all participants, dignitaries, and special invitee guests. It's a real great pleasure and an honor to hold this another episode of Cancer Webinar Series under the aegis of Onco Integrated Research Foundation in association with NIGF and GOGS, Gorakhpur, supported by Dr. Chaturvedi Cancer Hospital, Basharatpur, Gorakhpur, and electronic team of ClearNet. Today we have with us a very learned, talented, and astounding, brilliant speaker, Dr. Sahana Punne Shetty, who will do her debut from our society, and she is a consultant surgical oncologist in Fatima Hospital, Gorakhpur, and she shall be taking topic on non-gestational trophoblastic neoplasm and gestational trophoblastic choriocarcinomas, non-gestational choriocarcinomas. So let us have a CV of Dr. Sadhna.
Yeah, everybody knows. It's okay.
Okay.
It's okay.
As a presiding over the webinar, we have a wonderful lady who has all the great qualities of leadership and who has an intellectual quality of growth, who is an academician and by nature and has a balanced attitude, but a renowned and down-to-earth gynecologist of our city, Gorakhpur city, whom we refer as President NIGF, Dr. Sadhna Gupta. We invite you to bless us with your few words.
Thank you, Deepti. First of all, hearty appreciation, Deepti, Dr. A.K. Chaturvedi Hospital, that you are continuously, like I think it is since 1.5 years or 2 years, that you are constantly keeping these academic sessions, and especially on oncology, which many like gynecologists actually don't want to like invest into that knowledge, but we know that the cancer is something, one of the most important non-communicable disease, and which is hitting hard the low middle income countries that include India. And in India also, the accessibility to good quality oncology service, especially in the second and third tier cities, is a great question. So hearty congratulations for all these efforts, because when we have the continuous interaction, we are sensitized, we are more knowledgeable, and we know what to do for these patients who require the multidisciplinary care. So today the Shahana is going to speak, and it's great to have the people who are working in this specialty, especially in the oncology field, and they are doing very good work in our city, including Dr. Chaturvedi Hospital, Fatima, and the many more hospitals, because that is, again, I say, it is the need of the people. It may not be very paying, it may not be glamorous, but it is the thing where the patient need every kind of support, be it a clinical, surgical, multidisciplinary, financial, emotional, everything which is there, and the whole family needs support. So this is very like heartening that Sana is going to take, and the topic that choriocarcinoma. So sometimes we see choriocarcinoma or this thing, vesicular mole trophoblastic disease is okay, and every gynecologist can deal it. But always this is a something very potential issues for so many complications, and sometimes we are really troubled. And last year only, I have 2 cases where 2 and 3 DNCs has been done, and there is a in the primary gravid patient, no child, and it is invasive mole, β-HCG is not dropping, and the patient is having irregular bleeding. So this sometimes we cannot take any vesicular mole with lightly. It requires a very protocol based follow up counseling to the patient, and always the red flag sign that this patient is might be the choriocarcinoma or invasive mole, and regarding all fertility and reproductive issue, what best decision we can take. So we are looking forward. My regards to Savita ji. Yes, our very dedicated and a very quiet president, and we have a special association because Savita ji took charge from me for the GOGS secretary, and we did together a lot of like a trend setting program, the adolescent conference, which me and Samita as a organizing secretary was like one of the best, one of the first Foxy conference on the adolescent health, and that was in the Gorakhpur. So the Savita ji is a quiet person, but a wonderful organizer, and Alpna doing great job. She, her energy and her like taking everybody, and the multitasking what she does now, like cultural activities, and this way to the trip to Banaras, trip to Ayodhya. So it is something which is really creating a lot of fellowship, very close friendship, and we are not only the just colleague as a professional colleague. These activities which Alpna is making, Alpna and Savita ji are doing in their tenure, is actually increasing great fellowship and friendship, and that is again the need of when we are talking of cancer, like all these very clinical practices becoming very taxing with all Google, with all internet. We need to have hand holding of each other, and we need a very close friendship among ourselves. So great appreciation and hearty congratulations to Savita ji and Alpna for making every time our GOGS members on the go and making them happy. So thank you very much, Deepti, for the invite, and we look forward to the program.
Thank you so much for such kind words. It has really boosted our morale. And you are always, what you say, sweetheart. You are always a very good leader to look upon. Thank you so much. So now because Dr. Mala Srivastava, Secretary, NIGF, is in OT, she's also doing laparoscopy, oncology surgery. So is she there? So then I'll talk about her.
Mala,
Otherwise,
Mala. She has joined. I don't know. She is there.
she has joined through a assistant. Link is there, but she's in the OT. So we'll skip. Later on, I'll introduce her. We can talk about Dr. Savita, as already Madam has said. Dr. Sadhna has told about, but I'll say that she's real an inspiration for all of us. She's a very strong lady, and she is known for her strength and resilience. And little bit of her CV, because in between she had been out of the scene and not much to be seen, and now she's back with same vigor and enthusiasm. And I saw her CV; it was really worth reading. She is now the at present president of Gorakhpur OBGY Society, and she has been life member of IMA, FOXY, IAGE, ISCCP, UPCOG,
It's okay. Just pass
G,
on. It's okay.
and GB Association, IMS Society, Isopark Society, and she served as a treasurer, joint secretary, secretary, vice president of the GOGS. She has been advisor of Hindi health magazine, Neha, published from Gorakhpur. And as a secretary, she has organized many conferences, workshops, and CMEs. The workshops were on safe abortion in 2001 at Gorakhpur, CME on control of cervical cancer in 2002 at Gorakhpur, ICOG Zonal Conference on Adolescent Health. This is what Madam was saying, 2002 at Gorakhpur, and presented various scientific papers at AICOG, UPCOG, and NARCHI conferences. Attended various national and state level conferences as a delegate and chairperson. And she has written articles in Hindi magazine. Neha participated in many rural camps organized by the organization Neha. Received Appreciation Award on Women's International Day in 2001 for her excellent work in the field of women's health by Gorakhpur Midtown JC branch and Agrawal Mahasabha. Welcome, Dr. Savita Agrawal, and bless us with your few words of wisdom, knowledge, experiences.
Thank you, Dr. Sadhana and Dr. Dipti, for your kind words. And very good evening and happy Navratri to all. Dr. Sadhana, Dr. Dipti, Dr. E.K. Chaturvedi, Alpana, and Sahana, and all the participants of the today's webinar. Thank you, Dr. Dipti, for inviting me in today's webinar. And today's webinar, as already Dr. Sadhana has told, it is on the choriocarcinoma treatment update. Choriocarcinoma is a disease, though it is rare, but it is a dreadful disease sometimes. And choriocarcinoma can occur, we all know, following the normal pregnancy, even miscarriage, sometimes after ectopic pregnancy, and more common after molar pregnancy. 50% of choriocarcinoma occurs following the molar pregnancy. We cannot prevent the choriocarcinoma, but early detection is very important. If it is detected early, it can be cured 100%. But if it is late, then it can be cured 100% with single chemotherapeutic agent. But if it is detected late or in high-risk cases, multiple drug is required, and sometimes the surgery and radiotherapy also doesn't help much. So early detection is very important in choriocarcinoma, and thus the treatment. Today, Dr. Sahana has already spoken. Dr. Sahana will speak on the choriocarcinoma treatment update. So she will refresh our knowledge, and we should not take any case of molar pregnancy lightly. It should be followed up properly with the biochemical marker β-HCG, we all know, so that it can be detected in a very early stage and can be treated. So I wish good luck to all the organizers and Dr. Sahana for this talk. Thank you. And now over to Dr. Dipti.
I welcome Dr. Alpana, who doesn't know her, Secretary of GOG Society, a woman full of love, laughter, glamour, and already she has been appreciated a lot by Dr. Sadhana, and she's a very hardworking woman, gynecologist. And she has always had innovations to her work, and I welcome her. Little bit about her CV. She runs a testy baby center along with a super specialty hospital in Gorakhpur, Anand Lok Super Specialty Hospital. And she is now the secretary of GOG Society. She has been secretary of WDW, and she has fellowship in ART along with her UG and PG from KGMC Lucknow. Welcome, Dr. Alpna. Just throw some light on the today's topic.
Thank you, Deepti, for such a nice and really lovable words from you. And really, it adds to these words only make me and gives me innovations to do something. I'm really thankful to Dr. Savita ma'am and Dr. Sadhna ma'am for really giving me the appreciation. And these people are really my guides. You people are only my guides. And whatever I think, whatever I take the guidance from them only. And really, I'm thankful from the bottom of my heart to these people. And I welcome everyone in the society. I'm very, very happy Navratri to everyone. And really a heartily congratulations to Dr. Deepti ma'am, to you and to this Dr. A.K. Chaturvedi sir for organizing such type of CMEs and webinars which are really enriching our knowledge. Cancer is one thing which we are also very afraid of, and we think, अरे यार ये हमारा segment नहीं है, ये तो वो लोग जाने. But once you people train us, then we think over to those aspects, and then we think, yes, we can also do, and at least guide our patients to go to the right way, what to do next, because other things we can manage, but once it comes to the topic of cancer, we think no, we should guide the patient and go to the right man, to the right track and the right treatment. And really, I'm really privileged to be the part of this webinar. And really, Dr. Deepti ma'am and AK sir, we are really grateful to you because you always keep on posting some things or the other about cancers or not, and I always go through these. And
How nice.
then
The brilliance is seen on your face.
no, it's not that really. And I'm really thankful again, once again, to Dr. Sadhna ma'am. And today's topic, choriocarcinoma, as you said, choriocarcinoma is really a very deadly trophoblastic disorders. I just give a gist because Dr. Shana is there to elaborate to us. Just for the gist, I can only say a few words about it. That it is a trophoblastic, it is a very drastic trophoblastic disorders, and it can be gestational as well as it can be non-gestational, usually seen in the females, but it is also seen in the males. And both have got a different pathophysiology and different prognosis. So,
Exactly.
gestational is usually because of it is only found in the uterus, gestational especially, and it originates from the placental bits or from the placenta only. And one thing only I can comment is it has got a very, very good prognosis. I suppose I'm right in saying all this because I'm talking in front of the experts who are really very, very well versed in the choriocarcinoma and all that, especially Dr. Sir, Dr. A.K. Katriti sir, and Dr. Deepti man and Dr. Shana. And it has got a very, very good prognosis once the treatment is taken at the right time. Even I think even if the metablast, even it has the secondaries are there in the lungs, then also gestational choriocarcinoma has got a very, very good response, because I have seen one of my patients. She conceived, then twice she had this problem. She had the metastasis also. We sent her to the Patna. There she took the treatment, full-fledged treatment over AIMS over there. And now after 2 years of full-fledged treatment, again she's pregnant, and now she's having 6 months pregnancy. So this is a very good, but it has got a good prognosis.
Yeah.
And once again, I welcome everyone and thank you, all of you, for giving me the time to give. And really, I would appreciate your efforts and all. Thank you, madam. Thank you,
Okay,
Deepti
must
ji.
be
Thank
very
you, sir.
thankful.
And thank
We
you,
too.
Sadhna ma'am and Dr. Savita Agrawal ma'am, because they are mentor and guide for having all these activities.
Yeah,
Thank
brilliant.
you.
Okay, just remain with us and listen
Yeah,
also.
yeah. See, my dance teacher has come, so
Acha,
we are
dance.
practicing. But
Okay.
still, I'll be there till we start with the practice.
Okay, thank you so much
Okay,
for
okay. Thank you very much.
that is what na multitasker. अच्छा है ना म्यूट हो गई तुम muted okay, never mind. Okay, so and now again we have with us the person, the man behind these cancer webinar series, Dr. A.K. Chaturvedi, a renowned senior oncologist and the proud owner of Dr. Chaturvedi Cancer Hospital, with a record experience of treating cancer patients of about 40 years, and has been past president of UPRI and had extra trainings abroad, many awards and publications to add extra feathers to his cap, and a thorough gentleman. Yes, Dr. A.K. Chaturvedi. Now I hand over the dais to you. Dais is all yours, and you can give an elaborate to the subject and introduce our speaker. Questions will be put in the chat box, and they'll be discussed at the end of the meet. So, welcome, Dr.
Thank you,
A.K.
Dr.
Chaturvedi.
Thank you for introducing me. And thank you all, Dr. Sadhna, Dr. Alpna, and everyone who has come, Dr. Sabita, for nice words. We have started this, our Oncology Integrated Foundation, with the intent to give a common platform for the cancer patients' treatment, so that the like-minded people can come and discuss their problems on this particular platform. So today we have come with a new topic, choriocarcinoma, and that this is a very important tumor. It usually occurs in adolescents between the age of 20 to 30 years. Choriocarcinoma is an aggressive tumor. If not treated properly, it will be fatal. If it is treated properly in the early stage, it is 100% curable disease. So the choriocarcinomas usually are of two types: choriocarcinoma gestational and non-gestational, and third is unidentified. So gestational, that follows after gestation, maybe after miscarriage, abortion, ectopic pregnancy, or molar pregnancy, when the egg is fertilized. And primary non-gestational choriocarcinoma of ovary or testis is rare ovarian germ cell tumor, and this is arising from primordial germ cells. So it could be in the male or it could be in the female as well. But in the male, it is very fatal, and female also, if not treated properly, it is also fatal. Early diagnosis and treatment are important for better prognosis. Non-gestational carcinomas has got worse prognosis than the gestational one. And on these topics, we are inviting our learned newcomer in the Gorakhpur, Dr. Sahana Punnesetti. She is MCH Gynec Oncology, and she is MS Gynae. She did her MBBS from Mahadevappa Rampura Medical College, Kalburgi, Karnataka. Then did her MS ESI Medical College and Research Center, Bengaluru. She did her MCH from Christian Medical College, Vellore, which is a well-known center for the cancer treatment. It's a nice center and world famous center. Professional experience, she is right now working as consultant in the Fatima Hospital. Earlier, she was assistant professor in the Department of Gynec Oncology, CMC Vellore, Tamil Nadu. And she passed out. She has got many publications to her credit, many posters, many publications, and she has attended many national and international conferences. She has got interest in skilled. She is skilled in biopsies, colposcopies, conization, lead procedure, laparoscopic cystectomies, laparoscopic pelvic and parietic lymph node dissections, oncological surgeries, performed multiple radical hysterectomies, pelvic and para-aortic node dissections, diaphragm dissections, staging laparotomies, and HIPEC for ovarian cancer. HIPEC is a new concept, as you all know. She is also expert in, she has assisted in robotic surgery, assisted in robotic endometrial cancer surgeries, bowel resection, anastomosis, exentration, ileal, thondite, and stoma creation. So she is well experienced in gynec oncology. So I invite Dr. Sahana for her lecture, for her presentation. Kindly, stage is yours. Go ahead with that.
Thank you, sir. Thank you for your kind words. I'm falling short of words. It's my privilege to be a part of this society, and I would like to thank Sadhna ma'am, Alpna ma'am, Savita ma'am, Mala ma'am, and a special thanks to Dipti ma'am and sir for their continued efforts to bring oncology as a new branch and establishing it, and encouragement for the new doctors and giving them this platform. Thank you, and I would also thank Clarinet for this association and encouragement. I'll share my PPT, sir, now.
Okay.
Is it visible, sir?
Yeah, fine. Go ahead.
So we will be, I'll be talking on choriocarcinoma. In the overview, it is about introduction, their types, their diagnosis, their management, and certain scenarios. So before I proceed, we'll go back to history. When 1940, Hertz observed that fetal tissue requires high folic acid levels, and hence their growth could be inhibited by antimetabolites like methotrexate. Before mid-1950, there was no effective treatment available for GTN. It was in 1956 that Lee demonstrated methotrexate administration was found to have good remission in choriocarcinoma patients. That is how methotrexate began for treatment of choriocarcinoma. So what is choriocarcinoma? It is a malignant trophoblastic tumor consisting of trimorphic proliferation of intermediate trophoblasts, cytotrophoblast, and syncytial trophoblast in absence of chorionic villi. There are of two varieties, as we have been discussing, gestational and non-gestational, that is related to pregnancy and not related to pregnancy. They are broadly classified based on their origin as gestational and non-gestational. Non-gestational have again been classified whether it is of germ cell origin or non-germ cell origin. Germ cell origin, like germ cell tumors, they can be either gonadal in origin or extragonadal in location, and each has got its criteria for its definition. And non-germ cell origin is one where there is somatic mutation in the presence of a high-grade malignancy, or there is de-differentiation which has led to the malignancy. So if we see the non-gestational choriocarcinoma which has got germ cell origin, they are better comparatively to the non-germ cell origin. So germ cell origins are usually seen in younger, like adolescents, boys and girls, whereas non-germ cell are usually seen in elderly. So overall, non-gestational choriocarcinoma has poor prognosis compared to the gestational. So to establish a diagnosis, we need a histology and a HCG marker. Because histological diagnosis of choriocarcinoma is not always achieved in most of the cases, it is taken as a GTN and managed accordingly. So now brief introduction. Gestational choriocarcinoma, it arises from abnormal proliferation of trophoblastic tissue. As we know, it is a malignant variant. The rest of them are known as GTB. GTN, other GTNs include invasive mole, placental site trophoblastic tumor, epithelioid trophoblastic tumor. So what makes gestational choriocarcinoma unique is they are highly sensitive to chemotherapy, which renders them to have a higher cure rates. And this allows for fertility preservation, as these carcinomas are most commonly seen in reproductive aged women. It also has got a measurable excellent biomarker, β-HCG, that is human chorionic gonadotrophin, which is used in diagnosing the disease as well as for prognosis, and it is also used for post-treatment surveillance. So as I mentioned, GTD, the majority contribution comes for H mole, which accounts for 80%. The invasive mole accounts for 15%. Choriocarcinoma contributes to around 5%, and the other varieties include lesser than 5%. The risk factors, again, it is commonly seen in reproductive age, especially peaking between 29 to 39 years of age. It is more common in Southeast Asian countries, African countries, Middle East, less commonly seen in Japan. History of prior molar pregnancy is commonly seen in 50%, as Savita ma'am was mentioning. It follows abortion in 25% cases. Term pregnancy, tubal pregnancy account for another 25%. The etiopathogenesis of all the GTDs are paternal origin. That is, there is either dispermic fertilization or there is a suppression of the maternal gene, that is maternal genome imprinting happens. This leads to presence of two male haploid chromosomes, which can be either triploidy or it can be diploidy. Moving on to histopathology, grossly these tumors are they have got a very high proliferative index. So they are bulky tumors, proliferative, destructive. Because of excessive proliferation, there is devoid of blood vessels, and this leads to hemorrhage and necrosis. So in this picture, we can see that this is a cut section which is taken from the WHO edition. So these tumors are bulky and it can be found most commonly in the uterus, but it can also be seen in other areas like tubes, ovaries, lungs, GI, brain. Atypical manifestations also are seen in cutaneous, ocular, and endocrinological organs as well. So moving on to histopathology, this is a picture which is showing there are different types of cells. So choriocarcinoma, as I mentioned, it is a trimorphic pathology. So as we can see, syncytium, the purplish one where multiple cells are lying without any plasma membrane, that forms the syncytium. And the clear cells with prominent nuclear forms the intermediate trophoblast and the cytotrophoblast. In between, we can see the areas of hemorrhage and necrosis. So these are invariably present. LVSI is common. Cytological atypia is generally striking and mitotic figures are numerous. So now IHC is the gold standard in use in pathology. So these tumors, if we see syncytium is positive for HCG, human placental lactogen, inhibin. SAL4 negativity is a feature of choriocarcinoma. If SAL4 is positive, it is not a gestational choriocarcinoma. So MUC4, MCAM, P63 are positive for intermediate trophoblast. And these tumors, because of high proliferative index, they have high Ki67, index is high. So genotyping or genetic profiling, what we say, it is the only test which differentiates the choriocarcinoma, that is gestational choriocarcinoma, from a non-gestational choriocarcinoma. In genetic profiling, the patient's peripheral blood sample and her male partner samples are taken and they are compared with the tumor sample. So if it coincides, that is maternal genomic imprinting is present, it is suggestive of a gestational origin. If it is not there, it is suggestive of a non-gestational origin. Moving on to signs and symptoms, gestational choriocarcinoma are masqueraders. They have multitude of symptoms, and the most common symptoms are abnormal bleeding vagina, which is seen in nearly 80 to 90% of the patients. They also present with uterine enlargement. They can present with theca lutein cysts, which is causing pain, abdomen, torsion. And the other symptoms depend on the site of organ which is involved. 30% of these patients present with metastasis. As I mentioned, it depends on the site of the organ which is involved. If then lung involvement is there, they usually come with cough, hemoptysis, dyspnea, chest pain, and secondary pulmonary hypertension as well. This is because of occlusion of the pulmonary arteries with the trophoblast. Most of our patients, sometimes young ladies, comes only with lung symptoms. Vaginal, it can be asymptomatic or patients can present with profuse bleeding. Liver, again, asymptomatic to capsular rupture and hemorrhage. Brain, they can present with focal neurological deficit, convulsions, intracranial hemorrhage. Sorry. The pattern of spread, if we see early hematogenous spread, is characteristics, and that is why it can be fatal if it is not treated. Pulmonary mets are the most common, which account for 80%, followed by vagina and pelvis, liver and CNS, and there are great metastasis to spleen, kidney, and GI. As I said, atypical manifestation can be seen in ocular, cutaneous, even maternal to child transmission has been reported, and as well as development of disease in an organ transplant has also been reported. So before we go on to the prognostic scoring, the HCG, HCG is a human chorionic gonadotrophin, which has got a half-life of 1.5 to 3 days. So this HCG falls by log of 18. For normally, it takes 9 weeks for the HCG level to fall to normal. The normal value is less than 5 milli-international units per milliliter. So anything which there is plateauing or there is a deficit of fall, this should lead us to suspicious of a GTN or some abnormal trophoblastic activity. So how do we diagnose GTN? The FIGO has given us a criteria, especially for the post-molar GTN, which is again taken even for the choriocarcinoma, when there is plateauing of HCG for 4 measurements over 3 weeks, or rise in HCG for 3 measurements over 2 weeks, or there is histological diagnosis of a choriocarcinoma, we take it as a GTN and then the treatment begins. So Investigations which we generally require are HCG, and this HCG assay should be a double sandwich assay because it has to detect multiple variants of HCG. The HCG which is found in pregnancy is different compared to the HCG which is found in these pregnancies. These HCG are heterologous and they fragment, and this leads to presence of many multiple HCGs, like different forms of HCG, like it could be beta-HCG, cross-linked HCG, free form, nicked form, hyperglycosylated HCG. So the assay should be able to detect all forms of HCG. The patient also requires a complete blood profile, renal function, liver function, because these will be subjected to chemotherapy eventually. A basic examination with a chest X-ray and USG abdomen pelvis is good enough for the treatment to stage the patient and score the patient before we start the treatment. Only if the chest X-ray is positive for any presence of mets, then we go for a higher investigation like CT abdomen pelvis or a MRI brain. When it comes to imaging of the brain, MRI brain is more sensitive than CT for imaging. So each cancer has got a staging which includes 4 stages. This is adopted from the FIGO staging classification 2000, where the stage 1 is usually confined to the organ of origin, that is strictly confined to the uterine corpus. Stage 2 is when it extends to the adnexa and the vagina, but it is limited to genital structures. Stage 3 is when it extends to the lungs with or without involvement of the genital tract involvement. So any lady who can come with lung symptoms without any with absence of any tissue in the uterus still falls in stage 3. And all other metastatic sites go to stage 4. So with staging, this is the unique cancer where we have a score to categorize the patient into low risk and high risk. This also lets us to know that which patient will be more chemo resistant or like chemo responsive to single agent, multi-agent, and thus acts as more like a prognostic score. So this was devised by WHO and is now accepted as a FIGO score. This includes 8 features are taken, that is age of the patient, antecedent pregnancy, interval from index pregnancy, pre-treatment HCG values, larger tumor size, the site of this metastasis, number of metastasis, and previous failed chemotherapy. This is where the usual confusion comes, that which value is taken as a pre-treatment HCG value. It is always when the patient is referred to you because of not falling HCG levels, that value is taken as a pre-treatment HCG value and not the HCG which is diagnosed at the time of her molar pregnancy. As we can see, there is no number 3 in this scoring. So any patient who falls in 4 is considered as a very high risk and they automatically fall into the high risk scoring. Involvement of brain, liver, GI is taken as high risk. So based on these scores, they are given and categorized into low risk, high risk, and ultra high risk. Low risk includes 0 to 6, high risk is 7 to 12, and ultra high risk is more than 12. Based on this score and the stage, they are categorized as a stage, which is mentioned in a Roman letter, colon. Score is given in an Arabic numeral. Moving to treatment, chemotherapy is the gold standard and primary modality of treatment for these patients. For low risk, again, because choriocarcinoma is always taken as a high risk thing, these patients are uncommonly to fall in the low risk category. In low risk, we give single agent chemotherapy with cure rates nearly 100%, and high risk and ultra high risk need multi-agent chemotherapy, and still we can see that the cure rates in even in this category is 80 to 90%. Low-risk gestational choriocarcinoma, it is an uncommon entity. 8-day methotrexate is the recommended first line of treatment for these patients. Patients who are have developed toxicity to methotrexate or are having contraindications, they are given the option of actinomycin. There are different regimens, but the 8-day is the ideal regimen with a success rate of 74 to 90%. Where it is similar to the one which we give in ectopic pregnancy. Methotrexate is given as 1 mg per kg IM on alternate days with folinic acid to give us folinic rescue. This is repeated every 2 weekly. So all the chemotherapy here are given every 2 weekly till her HCG levels, with monitoring of HCG levels, till they fall normal, that is below 5 milli-international unit per ml for 3 consecutive weeks. This is followed by giving of consolidation cycle for 2 to 3 cycles. Then next is actinomycin. The most commonly used actinomycin regime is 1.25 mg per meter square IV every 2 weekly, which has got a remission rate of 69 to 90%. This is more convenient, more practical, and more adherence with the patient. So if we see methotrexate and actinomycin, methotrexate is always preferred first because of the toxicity profile is better with methotrexate compared to actinomycin B. Actinomycin toxicity patients can develop, especially those IV reactions. That is an irritant, so they typically develop reactions to actinomycin. But still, it is a better drug when patient does not respond to methotrexate. So chemotherapy resistance, how do we know resistance is when there is it is indicated by plateauing of HCG values over 3 consecutive cycles, or there is rise in HCG that is more than 10% change over 2 consecutive cycles. So anything this if there is any point of treatment, if we encounter these kind of things, we restage the patient with again a imaging and calculation of a new score and a new stage. So second line agent is then initiated depending again on whether the patient falls into low risk or high risk. Hysterectomy with bilateral sulfangectomy can be considered, especially when the patient has completed her family, and it is not a replacement to chemotherapy. It is only hysterectomy. Doing a hysterectomy, we are trying to reduce the tumor bulk and trying to put the potent cells into active mode. The cycles, we are trying to put the cells into the active mode so that they are more responsive to chemotherapy. Moving on to high-risk gestational choriocarcinoma, multi-agent chemotherapy revolutionized the treatment of GTN since 1970. The primary drug was used only as MAC, that is methotrexate, actinomycin, and cyclophosphamide. This was followed by Chamoka, which also had good response, but the toxicity profile was too high. Etoposide addition to the imaco had higher remission rates and tolerable toxicity profile. Patient adherence to imaco was also very good. The complete response rate was seen 62 to 78% with a survival rate of 85 to 94%. So this is the regime which is adopted from the FIGO criteria. So this comprises one cycle. On day 1, we give etoposide, actinomycin, and methotrexate. The next day, that is day 2, we give EA. After 1 week, the second, that is on day 8, vincristine and cyclophosphamide are given. This day 1 to day 8, this comprises one cycle, that is for 2 weeks. So after 2 weeks, this is again repeated. It is on a similar mode till the HCG falls down, and after that consolidation cycle of 2 to 3 cycles are given. The other regimes which are commonly employed, it is imaco. Apart from imaco, it is IMA-EP. Here, if we can see that that is cyclophosphamide and vincristine, are replaced by etoposide and cisplatin on day 8. Or EP and IMA. Though both are same, in EP and IMA, we start with induction, that is etoposide and cisplatin, which is especially given for ultra high-risk tumors. Then the other regimes are TP and TE, that is paclitaxel cisplatin or paclitaxel etoposide. Then based on germ cell tumor response, there is use of BEP regimes, VIP, ICE, and these are like historical to mention, and for completion, Chamoka, BEP, and MFA. So now what is ultra high risk? Any patients who have the scoring of more than 12 fall into this category. They have poor prognosis and require immediate induction of chemotherapy. That is, we start the chemotherapy with etoposide and actinomycin, where this is given to avoid tumor lysis syndrome. That is, the tumor load is so high that if we give the imaco at the regular dose, patient might collapse because of the dying cells. So here we induce with etoposide 100 mg per square meter and cisplatin 20 mg per square meter IV. This is given every 7 days for 1 to 3 courses depending on the patient's response prior to initiation of imaco, or it could be IMA-EP as well. Even with this regime, overall survival rate is around 94% and death rate is 0.7%. Moving on to treatment of metastasis, again the symptoms and the treatments are directed towards the site of metastasis. CNS metastasis are seen in 20% of the patients. Here, the dose in imaco, if we had seen, it is 300 mg of per meter square of methotrexate. In ultra high risk, where the CNS involvement is present, the dose is increased to 1000 mg per square meter area. Whole brain radiation therapy with stereotactic brain radiation therapy is given to especially patients who are having convulsion seizures. Intrathecal methotrexate total dose with combined with or without imaco is given. Craniotomy is reserved only for emergency cases for acute decompression. Hepatic mets, if it is oligometastatic involving only one segment, hepatic resection or selective embolization or occlusion are given in selected cases, depending on the center and availability. Pulmonary mets, isolated pulmonary nodules which are resistant, can be treated with thoracotomy and wedge resection, followed by chemotherapy. Vaginal mets are seen in 4 to 9% of the women, and 30% of these women experience significant bleeding. Especially these lesions, if they see, we are very friable and should never be biopsied, and they are located typically on anterior wall of the vagina. Bleeding from these metastases can be controlled by packing or radiation or wide local excision. Alternate approach is arteriographic embolization of the vaginal branch of internal iliac artery. So patient with metastasis in the brain, liver, and GI, they have a survival rate of 75, 73, and 50. So how do we follow these patients post-treatment? Low-risk patients are followed. Both the patients, the measurement of HCG is weekly until they're negative for 3 consecutive weeks. In low-risk, monthly HCG is done for 12 months, and in high-risk, it is done for 24 consecutive months. During the entire treatment of post-treatment surveillance, one should be very careful that patient is on effective contraception, typically on a OCP. This is because the HCG shares its component with many other hormones, especially the luteinizing hormone, which can mislead to our HCG follow-up. So it not only prevents contraception, it also suppresses the endogenous LH and thus allows us to monitor the HCG assay thoroughly. So moving on to the R's of the choriocarcinoma, there is something called as remission, recurrence, and resistance. Remission is defined as HCG is undetectable for 3 consecutive weeks. When it re-elevates after becoming undetectable for 3 weeks, it is called recurrence. Resistance is one when HCG remains elevated or plateaued despite the treatment. In these cases, we adopt something called a salvage chemotherapy. 30 to 40% of high-risk patients will have incomplete response. In these patients, as I prior mentioned, that EMA-EP or EP-EMA, that is induction, are considered the most appropriate therapy for patients who are responded to IMACO but have plateauing HCG or developed re-elevation. In these patients, response rate is still good with the 75 to 85%. Other regimes can also be tried. Overall success rate of salvage therapy is about 80%. Refractory choriocarcinoma cases, that is where despite multiple agents of chemotherapy and multiple cycles of chemotherapy, newer options are high-dose chemotherapy with peripheral stem cell transplant, immunotherapy. High-dose chemotherapy with peripheral stem cell transplant, it is commonly seen in hematological malignancies where initially chemotherapy is given and then stem cells are transfused into the patient, which causes the response rate. It is used in only it is under trial, and studies have shown a better response rate of almost 45%, but did not show much improvement on the long-term survival. So HDC can salvage a significant portion of women with refractory choriocarcinoma who have received multiple cycles of chemotherapy in few cases of placental site trophoblast and even epithelioid trophoblastic tumors. Immunotherapy. The concept of immunotherapy is really hot, and it has been employed in almost all the cancers, even gynae cancers. So if we see here the T cell, this is the cell which is in blue, and the tumor cell. It has got a programmed cell which is PD-1 and its ligand PD-L1. So when these two together they combine, it prevents the T cell from mounting an immune response. So when we are using a PD-L1 inhibitors, pembrolizumab, this interaction is inhibited and it allows our T cells to become active and act against these cells. So pembrolizumab showed a durable response in metastatic choriocarcinoma case. There are multiple drugs which are under phase 2 trials for and supports its use in refractory cases of choriocarcinoma. Avelumab is another such drug which supports its normalization of HCG values. The other agents which have been tried are gemcitabine, capecitabine, 5-fluorouracil. And these GTN tumors, they strongly express these PD-L1 ligand among them, and hence they are really good responsive if we employ the immunotherapy. So these are the few trials which are under phase 2 trial which are being employed, like avelumab, pembrolizumab, and dostarlimab, and the results of these trials are awaited. So cause of death, if we see in these patients, it is one is if they're not being treated at the right point of time, and hemorrhage from metastatic site, especially the lung, GI, they account really nearly for 42%. Pulmonary insufficiency, toxicity to chemotherapy, embolization, pulmonary embolism, obstructive uropathy, chemotoxicity, and even sepsis. Hysterectomy indications for in these tumors are when women has completed her family, no longer desires to keep the uterus. Chemo-resistant diseases to control uterine hemorrhage, especially if the imaging is suggestive of a tumor so big that it is involving myometrium, causing thinning of the myometrium, where there is impending risk of having a uterine perforation and hemorrhage into the peritoneum. This reduces the tumor load, puts the cells into an active mode of the cycle, and make them more responsive. Non-gestational choriocarcinoma, a little highlight on these tumors. So as we know that gestational choriocarcinoma, they're highly responsive to chemotherapy. And one of the theory which is postulated is because they don't have P53 aberrations. P53 is very notorious and these tumors are very bad tumors. In non-gestational, P53 is especially implicated in its etiopathogenesis. These tumors, again, as we initially described, they are either of germ cell origin, non-germ cell origin, which can be again gonadal, extragonadal. These are extremely rare tumors. Ovaries only account for 0.6% and uterus is still lesser than compared to the ovary. They can also be found in males like in association with the seminoma component. Pure choriocarcinomas are rare. They are usually found with again mixed germ cell component like it could be embryonal carcinoma, exact tumor, dysgerminomas. These tumors are highly aggressive. They have a more lymphatic spread compared to gestational choriocarcinoma, which has a hematogenous spread. Again, gonadal, they are commonly seen in children and young women, and the non-germ cell origin are commonly seen in elderly women. In gonadal origin have a comparatively better prognosis compared to the non-gestational, which have very aggressive course. These patients' symptoms present with precocious puberty, vaginal bleeding, symptoms of thyrotoxicosis. So if we see non-gestational and gestational choriocarcinoma, they have more or less similar symptoms. They have a rising HCG values. They present with symptoms also, histological features are also more or less same. It is only genetic profiling which helps us to establish an origin of these choriocarcinomas. Otherwise, the picture of histology is also very, puts it in a dilemma whether it is which origin. Treatment depends on the same. If it is an ovary, like you can either opt for early stage staging or multi-agent chemotherapy. The chemotherapy agents which are commonly employed are based on germ cell, that is BEP and VAC. So this is a table which shows us the comparison between gestational and non-gestational origin. So if we see the age in gestational choriocarcinoma are commonly seen in reproductive age group, and non-gestational age is extremes, whether it is either seen in children and young adults and older adults. However, there are exceptions to all the tumors. Paternal genetic component is present in gestational choriocarcinoma, and in non-gestational, it is consistent only with that of, it is not related to paternal origin. So if we can see the multiple IHC which we were discussing are present in gestational choriocarcinoma. In these tumors, we don't find a P53 mutations are commonly encountered in these kind of tumors. They have a hematogenous spread and non-gestational has more of lymphatic spread. Response to chemotherapy is good in gestational choriocarcinoma compared to the non-gestation, which are poor responders to chemotherapy. And prognosis is also better in gestational. Even with stage 4 disease, the prognosis is better with gestational choriocarcinoma compared to non-gestational choriocarcinoma. So these are few common things which we encounter, that is uterine AV malformation, especially patients who have been having GTN. They're commonly on imaging, ultrasound or MRI, they are found to have AV malformation. These patients can be asymptomatic and or symptomatic. They'll usually come with intermenstrual bleeding, continuous menorrhagia. So this can persist for months to year post remission. Even after a GTN treatment, if the patient is having a lung mets or a brain mets, the lesion takes time for disappear even post treatment. It usually gets fibrosed and it takes months for it to completely disappear. So patients can present with menorrhagia. If she is young woman, she'll have difficulty in conceiving. So the diagnosis is established with uterine Doppler or a MRI imaging. Treatment again depends on the need of the patient. If patient is willing for fertility, uterine artery embolization can be tried, but again the fertility rates will be poor with the embolization. And hysterectomy is offered to those patients who have completed family and who are having very intractable symptoms. So the usual scenarios which we see are many patients ask us role of prophylactic chemotherapy post-molar pregnancy, and how do we manage patients who come with persistently low HCG levels. So, role of prophylactic chemotherapy has been well established, but however, this should be reserved only for special cases where you know that patient is not going to come for follow up, and patient is not very very adherent to the further follow. So, this reduces the post-molar GTN to 3 to 8%, which can, if in absence of chemotherapy, it will be 15 to 20%. By giving prophylactic chemotherapy, that is methotrexate, we are trying to reduce to 3 to 8%. And how do we manage patients with low HCG? Is thorough HCG assay is very important, because we know that there is something called as glycosylated HCG molecules, which are bigger molecules, and they are taken as phantom HCG, and they can give you false reading. In such cases, you do either a urine HCG, because they do not cross the renal tubules, and it will be negative. Second is the HCG assay should be really good, and we can dilute the serum. If it is false HCG in dilution, it won't be detected. If it is a true HCG, in dilution also we will get to know the HCG value. So next is to rule out quiescent GTN. Quiescent GTN is a condition where HCG levels persist over like 4 to 6 months continuously in the range of less than 200 milli-international units per ml. In such patients, it is important that there is one form of HCG which is called as glycosylated HCG. Presence of glycosylated HCG helps in trophoblastic invasion, establishing the pregnancy. So if this is found, it means that patient is at risk of developing a GTN. So these patients should be on periodic follow-up and should not be over-treated with chemotherapy unless and until it is proved that it is malignancy. Thank you.
Yes, any questions? Clarinet team? Are there any questions in the inbox?
Okay.
What will be the dose
Am
of
I audible
prophylactic
or not?
chemotherapy?
Ma'am is asking a question.
Yes, ma'am.
What will be the dose of the prophylactic chemotherapy in low risk cases? If the
Ma'am,
patient is not coming
it is 1 mg per kg body weight, ma'am.
for how long?
Ma'am, just
Less
one
of
dose,
single
ma'am.
dose. One dose.
Yes, ma'am.
Okay. IM.
Yes, ma'am. I am, ma'am. I am, ma'am.
Okay. Thank you.
Yes.
Sana, you have covered very nicely all the aspects of the choriocarcinoma, its treatment, signs, symptoms, and diagnosis, and risk score and prognostic value, and the treatment very nicely. I had some work, so that I told Dipti that I will leave in between. But your lecture was so good, so I didn't feel like giving it.
Yeah.
Thank you, ma'am.
Dr.
you.
Sana,
And kudos to you.
really, it was very nice presentation. You have covered every aspect, starting
Thank you.
from all types of chemotherapy in the low risk group, medium risk group, and high risk group. So you start from methotrexate to MACO and EMA, EP and all. Then you have come to this immunotherapy. So pembrolizumab and avelumab. These are very common, and we are waiting for the results.
Yes, sir.
This advanced in advanced choriocarcinoma, it's very difficult to control. Really very difficult. And
Yes, yes.
especially when the lung mets are there or it has gone in the brain, it is very difficult to treat the patient. Craniospinal radiation we can continue along with intrathecal methotrexate, 12.5 milligrams.
Yes, I
Yes, sir. Yes, sir.
But
And I think the counseling part is also very difficult in these patients because they don't understand GTN is a malignancy. It is easy to explain them as a cervical malignancy or endometrium, but GTN malignancy, it's too difficult to tell them the diagnosis.
Very good. So it's really very nice, and we would like to have such type of presentations from your side. Since
Yes,
you
sir.
are
Definitely, sir.
MCH gynecology, that too from Adyar. I'd love to have you.
Definitely, sir. I'll be more than happy to be a part of this.
Most welcome.
Yeah.
Welcome. Thank you so
Bright
much.
and
Is there
brilliant.
any question? You can go ahead with that. And, I have to see one page.
No, it's now concluding.
Okay.
Any other questions? I'll take. If there are any questions, In the inbox, Clarinet team, paste it here. Team has also disappeared because it is Navratri.
Yes, ma'am.
Anyway, I'll conclude with this kind words. Thank you so much for accepting.
Thank you, ma'am.
And thank you, Dr. Sadhna, ma'am, Savita.
I think there's one question, ma'am. It's how frequently to follow up. Ma'am, it is better to follow them at least every 15 days.
Yeah. Anything without follow-up is incomplete. Any
Yes,
cancer, even our simple obstetrics also, we should do a follow-up. Gynae also, we should do a follow-up. Because
Yes,
if
yes.
it is left to follow up, then the treatment is incomplete. फिर वो
Yes.
इल्जाम सब अपने सिर पे ही आएगा. So, and instead of regressing, it will expand more and it will
Yes,
metastasize.
yes, ma'am.
So, can we end now? Are there any other questions? Even if they are quiescent, that is what she has asked. The doctor.
Yes, ma'am.
Vijay,
That's what I'm. How frequently to follow quiescent GTN cases?
even if they are
Because
quiescent.
weekly, yes, ma'am. Weekly is little difficult for patient to adhere to follow up. So even 15 days should be better.
Yeah, that is sufficient. And HCG titers will be seen and
Yes,
medicine
ma'am.
accordingly will be taken. So nice of you, very nice and intelligent, elaborate,
Thank you so much, ma'am.
and crisp talk. We were all enlightened by the extra things that you added to your deliberation, and
Yes, ma'am.
always be calling you again and again. So thank you,
Definitely.
the team, Clarinet, and thank you, NIGF, GOGS, President, Secretary, ma'am, and all for accepting my invite and participating in this. So we leave for the day, and next we are having on 15th. It is on
Okay.
breast and radiation management of surgical and radiation management of breast cancers. Okay,
Okay.
on
Okay, ma'am.
15th, 5 p.m. Thank you all.
Thank you,
Thank
ma'am.
you,
Thank you.
ma'am. Thank you,
Okay.
ma'am. Thank you so much, everyone, for giving us the opportunity to host the session. So, with all
Thank
your
you.
permission, I'm closing the session over here for today. Thank you so much. Good night.
Okay. Happy Navratri once again.
Same.
Happy Navratri, ma'am.
Time. Okay.